Good morning, everyone. As we begin the third day of the conference, we are examining now how global health law is essential in responding to the health threats of a globalizing world, where no single country or border or wall can prevent the spread of disease alone. And yet the COVID-19 pandemic has tested the essential legal foundations of human rights in global health. In the coming months, reforms of global health law provide a path to strengthen human rights to meet future public health emergencies. Will we take that path? Good morning. My name's Benjamin Meyer. I'm a professor of global health policy at the University of North Carolina at Chapel Hill, a senior scholar at the O'Neill Institute for National and Global Health Law, and the past chair of the Global Health Law Consortium. The Global Health Law Consortium is a research collaborative that brings together legal scholars throughout the world to strengthen global health. And our consortium developed this panel on human rights law to assess the human rights limitations that have been exposed by the COVID-19 response, and to analyze the human rights imperatives in ongoing global health law reforms, the reforms that are required to rebuild our world to face future global health threats. And I am doing something very, okay. I'm really using it. And so it is an honor to be up here fully mic'd and ready to introduce and moderate this panel on reforming global health law to ensure human rights in global health. It's an honor to introduce and moderate this conversation, and I'm really grateful to CUGH for hosting this conversation, to the University of Southern California for co-sponsoring this conference, and to Sophia Gruskin for ensuring a place for human rights in this conference's global health discussions. With a panel on global health law in each of the last 5 CUGH conferences, the Global Health Law Consortium developed this panel to underscore the centrality of human rights in global health law reforms, examining how we can look to human rights to face future global health challenges. I look forward to discussing the need to overcome human rights challenges in these sweeping global health law reforms that are being undertaken in the coming weeks. I hope to introduce you to this timely discussion by drawing from my own work with Larry Gostin over the past 5 years, leading to 3 new books that have helped to support human rights in global health governance through the COVID-19 response. In first introducing human rights in global health governance, I'll look to our first book on rights-based governance in a globalizing world, examining how human rights law is implemented in global governance within the World Health Organization and across the United Nations. Yet this global governance system has faced human rights challenges in the COVID-19 response. And I'll draw from our book on foundations of global health and human rights to detail the limitations of human rights in national responses to the pandemic, in international efforts to realize vaccine equity, and in efforts to ensure global solidarity through WHO governance. Given these governance limitations in global health law, I'll end by looking at our newest book, providing an overview of the WHO reforms that are necessary to bind states together in facing future challenges, before introducing our exciting panelists to speak about these individual reforms. Framing our discussions this morning on health and human rights, there we go. I hope to focus on human rights under international law as a basis for public health. By framing global health threats as rights violations, international human rights law offers global standards by which to establish legal commitments, clarify obligations, and evaluate policies and outcomes under law, giving rise to a health and human rights movement that has shaped the human rights that underlie global health. Human rights are now widely understood to be central to global health, offering universal legal frameworks for the advancement of justice in public health. As a basis for global justice under international law, human rights have evolved under international law over the past 75 years, offering universal standards by which to frame government policies and to facilitate legal accountability for global health. These global health governance institutions across the United Nations have come to look to human rights to develop their policies, their programs, and their practices, to promote global health across their own substantive expertise. And in developing shared rights-based governance across the United Nations, human rights have brought the world together over the past 75 years since the Universal Declaration of Human Rights, united in common goals for the advancement of global health through WHO. And yet these developments now face existential threats from populist nationalism, as populist leaders have fought to retrench nations inward at the very moment when global solidarity is needed most, in violent contrast with the global solidarity that's required in global health. These populist politicians have rejected public health science, denying public health data as a basis to neglect public health. They've denied human rights, restricting civil society and repressing minority populations. And they've undermined global solidarity through institutional attacks, with one nation going so far as to threaten to withdraw from the World Health Organization. As we noted early in the pandemic response, these attacks on human rights and global governance proved devastating to the pandemic response. Holding back our shared response to this common threat, populist leaders limited global governance and undermined human rights in the COVID-19 response. As WHO sought to hold the world together, the COVID-19 response revealed fundamental limitations of human rights. From the initial outbreak, delayed notification hampered WHO's ability to understand the scope of the threat and to coordinate an international response, holding back the WHO declaration of a public health emergency and delaying global preparations for a pandemic response. Moving into February, the world turns dark as governments responded to this public health emergency with overwhelming restrictions on international travel, on individual rights, on civil society, with these national restrictions violating explicit WHO recommendations. Regine Habibi's early work in the pandemic response, bringing together the Global Health Law Consortium to highlight these early violations of international law, would lay the foundation for our continuing international legal analysis to support WHO governance. And in our subsequent report for the independent panel on pandemic preparedness and response, we examined human rights violations across national contexts, detailing challenges to the right to health, in health system preparedness, and social and economic rights of vulnerable groups, especially during extended lockdowns. We focused on limitations of civil and political rights, with governments often using public health as an excuse to repress populations. And we focused on obligations of international assistance and cooperation, undermining global solidarity amidst this shared threat, and limiting, as we write with Sephora Abdul Karim, international obligations to ensure vaccine equity. Instead of coming together in collective action, states reverted to isolationist policies, discriminatory attacks, global neglect, exposing the global community to humanitarian upheaval, health insecurity, and human rights violations. Global health governance proved unable to mitigate this threat to global health and human rights. And this unprecedented threat now raises an imperative to reaffirm the universal commitment to human rights and global health. Reforms of global health law will be necessary to renew international legal obligations for human rights and global health. And so as we look ahead, WHO has mobilized its member states to establish new authorities that are necessary to realize the promise of human rights and global health governance. Where WHO has the constitutional authority to negotiate regulations, conventions, recommendations, these authorities are being applied right now in revising the international health regulations, in developing a new binding pandemic agreement, and in strengthening human rights in WHO governance and at the national level. In realizing this rising imperative for human rights in global health, I'm delighted to introduce you to the speakers who will be opening our discussion this morning. Sharing the human rights principles that have arisen out of the pandemic response and we look to in shaping future public health emergencies, we'll hear from Regine Habibi, an assistant professor at the University of Ottawa's Faculty of Law and a senior visiting fellow at UN University's International Institute for Global Health. Turning from these foundational principles to ongoing reforms, we'll be addressing law reforms underway in the World Health Assembly to revise the international health regulations, bringing into the conversation Larry Gostin, the faculty director at the O'Neill Institute for National and Global Health Law and the founding O'Neill Chair in Global Health Law at Georgetown Law Center. With not just one, but two reforms being undertaken simultaneously in the World Health Assembly, we'll then discuss the corresponding imperative for human rights in the development of a new pandemic agreement, learning from Safura Abdul Karim, a postdoctoral researcher at the Berman Institute at Johns Hopkins University and an adjunct professor at the Mailman School of Public Health at Columbia University. And finally, looking beyond these individual reforms, we'll discuss what this means for larger initiatives to mainstream human rights in global health, ending with Sophia Gruskin, a professor of medicine and a professor of law at the University of Southern California, and the director of the USC Institute on Inequities in Global Health. And now I'm going to turn it over to Regine and defer to our AV team to switch us to the next set of slides as we begin to focus on human rights principles and guidelines in public health emergencies. Regine?
Okay, as long as we have the slides up, I can see them there and I can see them there now. Okay, perfect. Well, thank you so much, Ben. Thank you for this really great overview of the discussions we're going to have together. Thank you for your leadership in bringing the panel together. And thank you as well to the CUGH organizers as well for this really fantastic event. As Professor Meyer mentioned, I'm an assistant professor at the University of Ottawa's Faculty of Law, and my work is primarily done on the unceded territories of the Algonquin Anishinaabe. And the work that I'm going to share with you today, much of what I'm going to share with you is drawn from the principles and guidelines on human rights and public health emergencies. And I will get to speaking in a little bit more detail soon about what those principles are, but briefly, they were launched just May of last year on the sidelines of the 76th World Health Assembly in Geneva. And they are a joint initiative really between two organizations. The International Commission of Jurists, which is a world-renowned international NGO that has promoted the rule of law and human rights since the 1950s, and the Global Health Law Consortium, which Professor Meyer has already introduced to you, whose work is and primary aim as a research collaborative is to build the field of global health law through research collaborations, consensus statements, and teaching. And the consensus building process that we took towards developing the set of principles and guidelines on human rights and public health emergencies was one that sought to consolidate international law as it relates to public health emergencies and human rights. And that involves not just consolidating standards from international human rights law, but of course looking to other regimes of international law that might have principles that are applicable to the context of public health emergencies. So I'll get into a little bit more detail of what those other regimes have to say about the subject matter or at the intersection of human rights and public health emergencies. This consensus building process really took us from the year 2020, at the March of 2020 was really when the ideas were planted to develop this work, up to about 2023 in May of last year, when we actually finally finished the work. And by the time we finished, we had consulted 150 individuals from academia, civil society, and the health workforce to provide input on what these principles should look like. The perspectives I'm going to share with you today, just as a disclaimer, and I encourage many on the panel who have been part of the consensus building work on these principles, and many in the audience who were also consulted in developing them. These are my own perspectives as someone who was part of the drafting committee, someone who was leading the consensus building process, but it necessarily is also a narrow view from my own perspective. And for the rest of the talk, if I'm referring to principles, just because the whole title is a bit of a mouthful, I'm referring to the principles and guidelines on human rights and public health emergencies. We know there are tons of principles out there, but this is the subject for the talk today. So what I'm hoping to do for the next few minutes is really to cover three bases. The first thing is I'd like to discuss the why of the principles. So why did we get to developing them? Why did we think it was necessary to develop them? The second bit is that I would like to talk about it a little bit, not a lot, because as you might see from the link there, which leads you to the principles are actually quite dense. They span 28 articles, and they really engage with international law in a deep manner. So what we're hoping to do down the line is also to develop advocacy toolkits, but for now, it is going to be a very brief overview of what the principles contain. And finally, just to give you a bit of an overview or a glimpse of next steps as to what we hope they will be used for, why I'm here even presenting them to you today, and what they can achieve potentially in the near and long-term future. Okay, I think we're going to the next slide. Yeah. So starting with the why, the initial why, of course, is that traditionally international law's perspective has been a narrow one on human rights in times of emergencies. The perspective has usually been one that's informed by what we call the Syracuse principles. The Syracuse principles were a consolidation of international legal standards that were developed in 1985 by a group of international lawyers who met in Syracuse one day and developed the principles. Well, not just one day, of course, this was a many year, I'm oversimplifying, but basically that was the framing of the principles, that it was a negative view of human. So when you take measures in times of emergencies, they must be restricted to the extent possible so they don't negatively affect human rights. The Syracuse principles had, of course, a paragraph on public health, specific to public health emergencies, which stated that public health may be invoked as a ground for limiting certain rights in order to allow the state to take measures dealing with a serious threat to the health of the population or individual members of the population. These measures must be specifically aimed at preventing disease or injury. So I've bolded the word there, limiting, or limiting certain rights. So the notion was always that if you take measures in times of public health, in times of a public health emergency, they must necessarily have an effect on limiting the rights of individuals. Of course, what we now know is that public health emergencies can also present problems where government measures are too lax. And in that sense, they can actually lead to infringements on rights, in particular the right to health and to right to life of a vast swath of the population in that affected area. So the narrowness of the Syracuse principles was one of the key driving forces in developing the principles and guidelines on human rights and public health emergencies. But the other bit of it was that it was also developed in 1984. We hadn't seen a lot of progression of human rights since then, of human rights law since then, and it had an insufficient treatment of the proportionality criteria as it relates to public health emergencies. For instance, concerns around scientific uncertainty and during an emergency that arises. We know fundamentally, of course, from COVID, and I will just skim through this because I think Professor Meyer has developed a very good overview already, that all human rights are universal, indivisible, interdependent, and interrelated. And this doesn't come just from our knowledge of COVID, which had vast effects not just on civil political rights, but also economic, social, and cultural rights, as well as our right to international solidarity. So our right to see that other countries are also concerned about our well-being in a country that might be heavily affected by COVID. And so, of course, this is something that we know all too well. I don't need to go into this too much, but COVID vaccine hoarding was one of the most egregious examples of failures in global solidarity, failures that international human rights law, I think, struggled to account for, and in particular, global health law certainly couldn't respond to as well. And so that leads me to the development of the principles themselves. As I mentioned, they are a consensus statement, and it took about 3 years to develop them. I won't go in too much detail over the timeline, though I'm happy to speak about the process if someone would like to probe in that regard, and how the development was. It was an overview of consensus statement, a consensus building process with international experts in international human rights law and global health law, but also a regional consultation drive with folks on the ground who had been responding to COVID and who had developed a rich depth of experience in terms of what a proper response, proper rights-based response to the novel crisis should be. And this process took us from 2020 to 2023, as I'd already mentioned. So just a brief comment on the architecture of the principles. Oh geez, I've not been changing my slides. I'm so sorry. Anyway. This is the architecture of the principles. This is what the kind of the outline of what they set out. And so of course they cover overarching human rights principles and obligations, human rights obligations relating to public health emergency prevention and preparedness, human rights obligations in times of response, and of course extraterritorial obligations in the context of public health emergencies. But what was the most difficult thing at the outset to agree on as a group was actually the definition of the principle of what a public health emergency is. We're seeing this play out, of course, in the pandemic treaty negotiations and in the IHR as well. There are some discussions of what type of event should trigger certain types of activities at the global level. For us, the key considerations were really that if we defined a public health emergency narrowly, basing it only on a declaration of a national state of emergency, then we run the risk of letting events fall under the radar and abuses and violations occur because there was no formal declaration announcing such an event. On the other hand, if the definition of a public health emergency is the one that we borrow from the international health regulations, which is a public health emergency of international concern, then we will count as important. We might count important events only those that have the basis of international spread, and not one that occurs within a very confined territory but has vast human rights implications. So we can't we had to come up with our own definition, and so this is what we landed on. Basically, that it refers to a newly emergent situation or the intensification in scope and or scale of an existing situation which, irrespective of source, can caused by a disease which poses an urgent and significant risk to human life, health, or the basic functioning of society. And this definition can, if you want, go as far as covering climate change events or heat-related events that have a major public health implication, intensification of this, for instance, of the situation. But we didn't go that far in the principles to thinking about how far they could be taken. We have always framed the principles as a living document, so that could be updated in real time in the future. And of course, I mentioned that they cover overarching human rights obligations. Some of these are sort of standard international human rights law canon. Some of them, however, are a little bit more of advancements in progressive interpretations of human rights law and global health law. So for instance, international solidarity, there are a great number of countries and governments around the world who might tell you that there is no international right to solidarity. The independent expert on the right to international solidarity mandated by the UN might disagree. So we try to take the most progressive interpretations out there that existed. And of course, human rights duties of non-state actors, this is one that poses a great deal of problems in the international human rights realm still, but we took the most progressive developments of international human rights law as it relates to non-state actors and regulating them, which came primarily from the Latin American context. I mentioned before that we drew not from international human rights law and global health law, but also from a broad base of other places and in international law. And one of those places, of course, was environmental law. We saw, for instance, that the precautionary principle, the countries that implemented a precautionary approach had made actually better strides in promoting a rights-based approach to COVID sometimes than countries that were too lax and did not take measures that were stringent enough. And so we made a good faith attempt at engaging with the precautionary principle in the context of human rights, which we haven't seen done very much in other in other domains of fields of work. So here we acknowledge that that in the context of uncertainty, a precautionary approach may be necessary, but we set certain guardrails on that approach. So, for instance, we thought that it might be appropriate to base them on public participation, that it should be accompanied by a full and widely communicated justification for those measures, and finally, that it should be continuously reviewed and repealed the moment it becomes clear that a less stringent approach, because of the nature of our understanding of the disease, might be necessary. So these are some of the things that are from the principles, that are advancements bringing together health and human rights that we sought to bring together. Now, 9 months later, after the principles were launched in May, there's been lots of activity on them. They've been cited by the Parliamentary Assembly's Council of Europe as something to follow, and the hope is that they eventually get incorporated into governance reforms, which others will speak to. So I will end there. I was terrible at changing my slides. I apologize, but I hope the gist of it was there with you guys. Thank you.
Good morning. I also wanted to thank my co-author and friend Ben for organizing this. Rujan's description of the human rights principles, I think, were really important and prescient because I was at the Syracuse principles originally and then had the honor of being with Rujan and the Global Health Consortium and the International Commission of Jurists, and she was a real hero. She is a real hero. So thank you for kind of spearheading that. It's a real honor for me to be here on this panel, also with Sephora and Sophia. Sophia and I go back to Jonathan Mann, the birth of the health and human rights movement. Remember, in the basement of Huntington Avenue at the Harvard School of Public Health with the chalkboard, and we were kind of thinking about the human rights impact assessment. So, and here we are, where human rights has become front and center. Sephora is going to talk about mainstreaming it. So these are really important issues. My task was to talk about the international health regulations, but rather than going through each of the various amendments that impact human rights, I thought it might be more helpful and explanatory to show the breadth of human rights and global public health. It's not just a very narrow area like an individual right that you might think. And so I thought I would start by talking about the IHR and what I call the balancing dynamic in those regulations, but then go to the various spheres or dimensions of human rights. One will be bodily integrity. The other will be autonomy and liberty. The third one will be on collective rights and the right to health. The fourth one on discrimination and the rights of nations and peoples not to be discriminated against. And the fifth one will be on the rights to equity and justice, just to give you the idea of the deep richness of the field that we all inhabit. I've always thought that the IHR, certainly since they were revised after the SARS epidemic, as a balancing dynamic. Yes, they're about global health security and to try to prevent the international spread of novel infections. but they're also about protecting international travel and trade, which is the second part of the dynamic. And the third part of the dynamic are human rights. And I think of human rights as really integral to the international health regulations. The regulations, as you know, start by saying that there needs to be full respect for the dignity of individuals, of human rights, and of the areas that people feel that they have their own rights fulfillment. One of the amendments to the IHR that was proposed was to take out this statement. I think that would be extraordinarily dangerous and really get to the undermine the heart of the regulations. I don't think that's going to happen, and it mustn't. So let me just briefly go through the various what I might call dimensions of human rights. The first is bodily integrity, the right to consent to treatments, to vaccinations and others, unless there's a compelling scientific evidence that that failing to be vaccinated, for example, would cause harm to others. The second is liberty and travel, and particularly international travel, where we found throughout the pandemic there was not just impediments to travel, which there were, but there were also discriminatory impediments, often targeted at particular individuals and communities. I'm going to talk a little bit more about travel and travel restrictions, but suffice it to say that at the peak of the pandemic, virtually the whole world had one form of a travel restriction or another, which really, in many ways, were in violation of the international health regulations, unless the country explained to WHO what the scientific justification was, and I don't think there ever were. The third is the right to health, or collective rights. To me, this is the most important part of human rights and global public health, because it says that every human being has the right to protection, health protection, protection against infectious disease, non-communicable disease, protection against injuries, mental health, sexual violence, and the like. One of the most important parts of the international health regulations are what are known as core health system capacities, which I think come as close to the right to health as they can. They don't really extend as far as universal health coverage, which we'd all like to see, and is one of the pillars of WHO's international priorities. But they do require the ability to have a health system that can rapidly surveil, detect, report, and respond to infectious diseases. This requires surveillance, laboratories, trained healthcare workers who can identify and treat novel infections. And it also includes good public health laws. Even before COVID, the Global Health Security Index had been evaluating health systems, and most health systems in the world did not meet the requirements under the IHR. And as we've written as a Global Health Law Consortium, there are provisions in the IHR that appear to kind of require collaboration and assistance in developing these core capacities, but those have never really been implemented. And so one of the hopes that I would love to see come out of the IHR, I'm not optimistic, is to be able to have a much more robust form of global solidarity in the form of providing financial, technical assistance, and peer-to-peer assessment, evaluation, and response to build up health systems. The fourth is discrimination, and it's really not just discrimination against individuals, but discrimination against nations, against peoples. As I mentioned about the travel restrictions, these appear to be in direct violation of the international health regulations. Countries didn't even bother to explain to WHO why they were doing it, and they did it in a very discriminatory and targeted way. The clearest example of that, I think, is when South Africa identified the Omicron variant, and they rapidly sequenced the genome of the variant and shared that around the world. This was exemplary behavior. This is what we want all nations to do. But rather than being incentivized to do that, rewarded to do it, or even thanked for doing it, they were targeted with travel restrictions against South Africa and actually against much of Southern Africa. That was just a disgraceful disincentive to all countries doing the right thing. And so discrimination, I think, is an extremely important part of this. The last part is the part that both Ben and Rujan talked about. My cousin. I turned it down. I don't know why it's going. It's usually a family member. Anyway, the right to equity and justice is, I think, at the heart of global public health. Equity is, in my view, even before COVID, was the predominant global narrative. It was the narrative of people who had and didn't have, both in economic terms, in social terms, in educational terms, and certainly in health terms, as Martin Luther King said, of all of the forms of discrimination that exist, health stands alone as being the most important. We saw enormous disparities despite the ACT Accelerator and the COVAX facility, and particularly, as Ben had pointed out, about the pre-purchase agreements that really gobbled up all of the world's supplies of COVID-19 vaccines. I'll finish simply by talking about this. There's been a lot of discussion. Alex Phelan has been one of the leaders of this about decolonization of global health. There's one thing I know. I've done a lot of work with the African Union and the African CDC and WHO Afro. And one thing that's been very clear to me is that the old model of philanthropy, of charity, has to end and must end, because everyone knows that charity comes too little and too late. And so what we need is self-reliance, the ability to manufacture medical countermeasures in real time, and the capacity to do that. That requires IP waivers, it requires technology transfers. One of the big issues that in the pandemic agreement now is the pathogen access and benefit sharing system. These are things that are extraordinarily important to equity. And if I were having talked to Precious Matsutsu yesterday, who's the co-chair of the INB of the pandemic agreement, she said that the major stumbling block is on equity. I can provide more details to that, but equity is the heart of the IHR, it's the heart of the pandemic agreement, and it's the heart of global public health. So thank you, and thank you, Ben, once again.
Sorry, I'm just waiting for my slides. Fantastic. Good morning, everyone. It is a huge privilege to be here today to talk to you about the new kid on the block, the Pandemic Accord. It's perhaps apt that I follow Larry's discussion of the central tenet of the IHR as a defining feature of global health law to talk about something that was at its inception envisioned to be a major reform and step forward in how we think about pandemic response and preparedness in global health law. The Pandemic Accord was envisioned and conceptualized in direct response to the COVID-19 pandemic and some of the issues that have been discussed at length by Regine, Ben, and Larry. The idea was that it would be this novel, new instrument, a framework convention on pandemic response and preparedness, and that it would fix the challenge of global coordination and international solidarity, two concepts that had been woefully neglected during the COVID-19 response. So it's considered and conceptualized not in replacement of existing global health law infrastructure such as the international health regulations, but in supplementation too, where the international health regulations are focused on, for example, surveillance and travel restrictions and controlling the spread of a pandemic. The Pandemic Accord was designed and envisaged the coordination and preparation of a global response to pandemics. So why does human rights matter for a pandemic accord? Well, the first and most obvious is what was discussed by Ben and Regine, which is the human rights failures and gross violations of human rights that occurred in the way that the COVID-19 response was initially applied. However, human rights can assist more than that. They offer a normative basis for global solidarity. And they offer a concrete way to support the prioritization of often neglected obligations regarding pandemic preparedness and response. Finally, and I think what is particularly important, is that they offer a basis to ensure equity in the distribution and access to medical countermeasures. Sorry. That is, of course, in an ideal world. But we live in a political reality. And so as the Pandemic Accord has developed, it's had to balance the tensions and competing priorities of two groups or two sections of our society. The first is what high-income countries prioritize as important in pandemic response. They want access to pathogens, they want access to samples, they want access to material and data. They also want their state sovereignty respected. That's unsurprising, given the nationalistic responses that many of them adopted during COVID-19. Unsurprisingly, people from low and middle income countries feel a little bit differently. Professor Gostin described some of the difficulties that people in South Africa faced, and having lived through them as a South African, I can confirm these were true. So the concern for low and middle income countries is issues such as equitable vaccine access and other access to medical countermeasures, making sure that there is sufficient funding to support pandemic response infrastructure, and also ensuring that intellectual property no longer monopolizes access and limits access to medical countermeasures to only those who can afford to pay for it. So how has these tensions been translated into a pandemic accord? Well, this is a brief timeline of how the Pandemic Accord developed. It was originally conceptualized in September 2020, when I think COVID-19 and the potential of future pandemics was high on everyone's minds. And so as a result, the World Health Organization moved quickly to convene a panel that ultimately recommended that a negotiation be launched. That was confirmed by the World Health Assembly in 2021, when I think COVID-19 was maybe a little bit further in our memories. And as the Pandemic Accord negotiations have progressed, it seems to me that what we've seen is that the further in our minds COVID becomes, the less inclination there is for solidarity and constructing a meaningful agreement that will really facilitate international coordination against future threats. I'm very happy to share that last night, the final negotiating draft of the Pandemic Accord was released by the INB. It's unclear whether that will be the version that's voted on, but they are definitely under some pressure to ensure that there is an accord that can be voted on in May of this year. So in other words, from September 2020, we are now at the final stages of this accord. The pictures on the right-hand side, I think, tell the story of human rights in the Pandemic Accord, and unfortunately, it's not a happy one. When the original Zero Draft was launched, it was considered a revolutionary and much welcome document that respected human rights, that foregrounded human rights as a guiding principle of the treaty, and emphasized issues such as equity and solidarity. An editorial published by The Lancet, which is the second picture, now refers to the pandemic treaty as shameful and unjust. And another editorial in Nature advocates for the final pandemic treaty to remedy some of the shortcomings that exist in the negotiating draft. The Pandemic Accord as it currently stands is being heavily criticized for moving us backwards. It omits discussion of well-established human rights principles. So in other words, not only does it not take us forward, it doesn't even recognize where we are. It also removed specific recognition and provisions that concretized human rights obligations and weakened the provisions related to equitable access for medical countermeasures. Various portions of the negotiating draft also put the accord in a position where it is subject to all other kinds of laws. Some of those are national laws, some of those are existing trade arrangements or other arrangements that have not worked in prioritizing public health and human rights. While the Pandemic Accord negotiating draft does discuss knowledge sharing and tech transfer, it leaves very troublingly the issue of intellectual property firmly within the trappings of the Doha Declaration, which again we saw did not work to facilitate equitable access to vaccines during the pandemic. This is just a really clear example of how the draft evolved. It went from a lengthy discussion of specific issues that needed to be addressed and issues of equity that needed to be prioritized in the Pandemic Accord to a flippant single sentence that equity should be at the center of pandemic preparedness. What does that mean? What issues does it cover? Those are all left ambiguous. And unfortunately, human rights has been left in a similar situation. In the most recent draft of the negotiating draft of the Pandemic Accord, the mention of human rights is limited as a guiding principle to ensure that human rights are respected in pandemic response. There is no further detail offered as to what should happen. So where do we go from here? Well, hopefully somewhere better. The draft treaty will proceed to the World Health Assembly for voting, hopefully in May of 2024, and members may decide whether or not they want to sign on to this. It's an opt-in instrument, not an opt-out. And while the INB process is effectively completed, there remains an opportunity for all of us as members of the global health community to advocate for this treaty to do something better, or at a minimum, to advocate within our own countries for those countries to do better. Thank you very much.
Thank you. Good morning, everyone. Hello. Okay. Oh, that's fine. Hello. Okay. I appreciate that. It's an honor to be here, and thank you, Ben, for including me. I really appreciate it. I want to start by saying that I am not an expert on these very specific processes, and so my hope is to add a bit to the conversation by broadening out and perhaps adding a bit of context. And I also want to say up front that some of the ideas I'm going to present are really not mine alone. I've been in conversations with many people over the last few years about the regressions that are happening in the areas of human rights in health, some of whom are in the audience today. And so I'm grateful for this opportunity, for what feels like a very active conversation for us all to be in. So if I can start in terms of context, if I can do this properly. Maybe I'm not doing it properly. I can talk even without, but there we go. Thank you. That is the right one. Thank you. Okay, thank you. So I just want to say in terms of context, I just want to underline a lot of kind of what my colleagues have said, that even prior to the pandemic and the issues in negotiations that we've been talking about, I think that we would all agree and that it's absolutely clear that there's a difference between the rhetoric around attention to rights in global health and the reality of attention to rights in global health. It's absolutely not new that human rights are not serving those most in need within countries at local or national level, that rights are not infusing policies and programs relevant to the most urgent crises, nor being adequately addressed by the primary global health institutions like WHO, even though these are the institutions that have the responsibility for upholding rights and health in their mandates. And we all know why this is. Eric Goosby said it yesterday, Keith Martin said it yesterday. Health is, and who has access to health is political. And even as rights are meant to transcend politics, as Ben, you talked about in your intro, the erosions of rights, protections in the name of public health, or as is happening in this country, the dismantling of public health institutions in the name of individual rights, not in the name of human rights, I might say. It's not new, but it's nothing if it's not political. And we always have needed to do more to address who gets sick and why, and importantly, who gets left behind and why, but also to maximize the role that systems of governments and accountability, like the sorts we're talking about here, can actually play in ensuring health for all. And it's never been more important or more urgent, if I may say, than these days. And I'm going to try to do my next. Oh, there we go. So, we have largely been talking about legal framing to respond to public health emergencies in this session. And I think we need to be extremely concerned about the latest drafts, the lack of compliance, the lack of accountability language that's in there. But evidence is clear from across the spectrum of health issues that we care about, that at both global and national level, politics are always at play. And here's the kicker. To ensure legal accountability for what is done over time, politics still matters. Governments are still the ones in the first instance who have to agree on the language that's put into these agreements, the terms, the mechanisms, and the global agreements they will sign on to. So therefore, even in the drafting, the finalization of these documents, politics and who is in power in all of our countries makes a difference to what shape these documents will take and what they will look like. And sadly, and I mean this over and above, what technical expertise and evidence might suggest is needed. But then even once these documents are finalized, the international legal system is only as strong as the extent to which the governments that opt in, that sign on, then live up to their commitments. And in that respect, there's been an issue forever about what states say they're going to do in global spaces and what they actually do in practice. And that matters, of course, for accountability, but it matters also for programming and to get things done. This difference between, to use human rights terms, difference between government incapacity and government unwillingness is central. But there have to be strong global agreements, the sort we've been talking about on this panel. So the area I know well is sexual and reproductive health and rights. So I'm using that to show you what I mean. But my focus on sexual and reproductive health and rights is not just sort of random. Sadly, the pushback that's happening these days against sexual and reproductive health and rights is actually one of the fundamental common traits of the pushback that's happening against human rights generally and of anti-democratic agendas. Throughout history, we all know that states, particularly but not exclusively authoritarian regimes, often begin to clamp down on rights more generally by starting with restrictions on rights in this area. And they do it in myriad ways, but ultimately they're all about seeking to control bodily autonomy and about how people live their lives. And this totally aligns with the well-coordinated and well-funded global pushback happening now against women's rights, against the human rights of lesbian, gay, bisexual, and transgender people, and against sexual and reproductive health and rights generally. And that in turn goes hand in hand with the pushback against democracy, against civic space that's happening all around the world, and all with implications for how as a world we will respond to the next health and human rights crises. So I hope you'll agree that SRHR is a useful example to use. So I want to set this up by saying that from my perspective, when we think about global agreements actually being able to make a difference in the world, any global agreement, there are two sets of issues to contend with. The first are the issues around negotiation of the language of the text itself, like what we were talking about here. Then there are the issues about implementation and holding states accountable for what's there once the language is drafted and agreed to. Both are always an issue. So always there's a question at this stage of the drafting. Is it better to go for a lower common denominator approach that more states will agree to and sign on to? Or is it better to hold out and get the document needed or closer to what's needed to ensure more attention to rights and better accountability for the key issues, even if it ultimately has a shorter shelf life or there are fewer takers? And in the context of global pandemics, I'd argue that this is not a small question. So let me show you what I mean, if I can make the clicker work. I did, okay. And to be clear here, I'm using political consensus documents to make the point, not legal documents. But from my perspective, I think it makes the point all the more. The International Conference on Population and Development, which is having its 30-year anniversary this year, is quite rightly seen as having been a critical step in moving population concerns away from demographic targets towards rights-affirming policies and programs. And the language is fine, but let me get into the weeds here. For a reason, key here is that for good or for bad, reproductive rights were defined only as part of and within the definition of reproductive health. And so reproductive rights are said to embrace certain human rights already recognized, blah, blah, within the definition of reproductive health. But they are not articulated as a separate part of the human rights commitments that governments have signed on to. And this resulted in a paragraph in a document that pretty much all countries were comfortable with. And it's the international agreement that continues with all of its problems to have real traction to this day. I compare that then to the Fourth World Conference on Women in 1995, which was the first articulation of sexual rights in an internationally negotiated document the following year. And I point out that the definition here happened in the health chapter, and it begins by building on Cairo, but as you can see, it explicitly grounds its articulation within the internationally agreed legal human rights framework. It was 2 weeks of negotiation to get this one paragraph, and it ended up with this legal grounding and calling for the human rights of women. And frankly, it felt like a huge one at the time. And even as today, we can find many things wrong with the language, which we can get into it if you like in the discussion. I raise it here because I feel very much attached to this paragraph, but it doesn't have the traction or the shelf life of Cairo, even as much more time was spent getting it right in the negotiation. And I think that's a political calculation that we have to reckon with. And so the point I want to make here is that the Cairo conference, perhaps because it was ostensibly endorsed by a majority of the governments of the world, to this day in 2024 remains the touchstone undergirding reproductive as well as sexual rights in all spheres. Now, can I say as a side note, it has to be said it's insane that we are now fighting to hold the line on language that was agreed to 30 years ago, which was inadequate then. It's a really sad place for us to be, but I hope the point is nonetheless clear. Let me take it one step further. And you can see how this played out in the Sustainable Development Goals, the globally agreed to blueprint for the future, which basically, as we all know, is about the idea of leaving no one behind. And note how the SDGs recognize sexual and reproductive health and reproductive rights in this really awkward formulation that only recognizes reproductive rights but not sexual rights. And that has had major implications for the targets and the indicators that were set, the data collected by countries, what funding is available, the programmings that are put in place, and actually who's left behind. So just think of it where, despite it being the one place in the SDGs where the word rights is actually explicitly mentioned, it's fairly clear that sexual rights, even at their most basic as understood in Beijing, don't exist, but reproductive rights do. And so building on Cairo that offered this rhetorical language but no legal grounding, reproductive rights are explicit, but sexual rights, which had some legal grounding, are not. So I have other examples, but I just say in terms of the negotiations that are happening now, my hope is that there's some value in thinking about how politics plays out into what's gained and what's lost over time in the SRH space through all of this. My hope is this can be strategically useful in setting priorities as we think about short and long-term outcomes to this work. So just to close, one fact that has to be at the forefront of all of our minds is this year, in 2024, there will be 64 major elections. More people across the world than at any other time in history will be casting their votes this year. That's approximately 49% of the global population. In 6 months, our world could look very different. Countries could turn to new and more just ways of organizing themselves, or they can fall into devastating patterns of regression and repression. Now, this includes countries like India, Russia, and the United States, all countries whose political decisions we recognize have immense global consequences, but also all the other countries where elections are happening, whose actions are nonetheless critical not only to what happens at home, but to what will get decided in these sorts of negotiations at the global level, let alone how once these documents are out and done and dusted, they're going to play out. 2024 as the super election year has to be a central theme in how we consider what's going to happen in May at the World Health Assembly and beyond. My point is simply that we cannot forget the power that existing and incoming politicians hold to shape the laws, policies, and norms around health and rights, and the relevance of that for what will and will not be possible for global health more generally. So in line with that, and in terms of just thinking about our strategic thinking, I think that I can't even do this. I was going to say, I think the most important thing that we all need to do this year is vote. Thank you.
So thank you to all of our panelists for really engaging the ways in which the time is now for focusing on many of these human rights advancements in global health law reforms. As we begin to take questions, and I hope that you'll form a line at the microphones in the center of the room, and can I ask the AV group to pull up the final slide from my introduction, which has the names of all of the presenters. I hope to at least open the conversation by asking myself, why have human rights proven so politically challenging in many of these intergovernmental negotiations and in a lot of the national reforms that need to be undertaken in order to strengthen rights for the future of global health? Larry?
Thank you. Yeah, Ben asked me to take the first go with this. I think there are 3 reasons, Ben. One is because in the minds of many leaders, particularly the populist leaders, the authoritarian leaders, but also even some democratic leaders, sovereignty is affected, and so they're afraid that if they agree to human rights, that somehow it affects their sovereignty. The second is that I think the world has very different conceptions of human rights and has, as you and I have written, since the Soviet era. Some see civil and political rights as the most important. Others see social, economic, and cultural rights as the most important. And so I think that this clash of rights is a second reason. The third is just relates to what Sophia was saying. It's geopolitical. And in realpolitik, it only takes one big country to push back and get human rights diluted or even excluded. The U.S. has been one of the ones who've done that, although I don't think the Biden administration, I think they've been pretty constructive. The EU, China, Russia, others. So I think between sovereignty, different conceptions of human rights, and the geopolitical realpolitik of it, it's a real hard slog to get human rights really robustly accepted in international negotiations.
And the flip side of this, Sophia, I hope to come to you to focus on accountability, or when you talked about living up to commitments. Once these commitments are made, assuming that we can get over some of the sovereignty obstacles, how do we make sure that they become real in people's lives? How do we make sure that governments are held accountable for implementing these rights at the national level?
Well, I mean, I don't have the answer clearly, but what I will say is you need strong civil society, and you need strength, and you need support for a strong civil society, and you need global solidarity. And I think it's so many of the things everybody on this panel has been talking about, which is what does it take to have that global solidarity and to have a strong civil society when we see these processes eroding. We see the kinds of organizations that supported civil society now eroding themselves. So there's not funding for civil society to come together. There's all of those things. So I do feel, I mean, I'm sincere, I feel like we're in a crisis at this point, right? But I still believe very much in the principles and very much in what's needed. But if you say to me, how are you going to make it happen? That's where I'm, you know.
Okay, we're going to turn to the questions at the microphone. I think I see 3 people there, and we'll just take all 3 questions and then turn to the panel to respond to them. But please feel free, if you have a question for a specific individual, those are their names, please feel free. Thank you.
Good morning. Thank you. I'm Lena Elseraff. I'm a physician. I work at a community health clinic in Los Angeles. I want to thank the presenters for presenting on this important topic. I think for me, what's on my mind that I can't stop thinking of is the genocide that's going on in Gaza. And as health experts and the lessons learned from dealing with public health emergencies, I'd like to have your opinion from all the panelists, an in-depth analysis on how do we stop a genocide and how do we prevent future genocide.
Hi, this is more of a comment. I'm Barbara Kamholtz. I'm a geriatric psychiatrist from UCSF. And the only thing because I'm a doctor, the only thing I know I've learned from my patients. So I want to make a comment about health literacy, and that can really affect rights. You need to know what's possible and what's not possible. What I've seen in Nepal is, sadly, a number of almost fatal attacks on physicians because people in the community do not understand what's possible for them to do. If a younger person dies for some perfectly reasonable reason, nonetheless, the doctor should have fixed that person. That person should be going home and not be, either in a hospital dying or dead. And this relates, and this is a problem all over Nepal. I'm not sure it's limited to Nepal. I suspect it's not. But this is a case of feeling that the right to health is the right to life, in a sense. And this is an unrealistic expectation. On the other hand, what I see in older people is often enough people are brought to the emergency room and they're sent home to die because there are no funds. That's a possible issue. If they know that a health organization can provide funds, they may let them stay, and they may enable them, or even to go to, to be sent to a higher center so that they can get care. Or they just feel, for cultural reasons, this person's time is done and there's nothing that can be done. Well, actually, for older people, if you understand, physiology of older people, a lot can be done. There are a lot of ways to, buttress the cardiovascular system, to increase muscle strength, but if you don't know that, you assume that that older person is never going to get better. So there's a tremendous, this is an in-the-weeds thing, but the education about what's possible and what's not possible, just as I've learned from this one country, I think is really critical, and I think we need to really focus on that. Thank you.
Hi, I'm Simon Rapkin. I'm a cardiologist at the University of British Columbia. So my question has to do with where one draws a line in terms of inequity and equity. So in the cardiovascular field, many of us put in very expensive pieces of equipment at great cost, and then certainly save lives. And then the concept of extrapolating that kind of effort globally means not only a tremendous amount of cost, but as well it challenges the rights that were set out. So can we put in prosthetic aortic valves across the world? It'll be something that will be certainly beneficial on a human level, but will be exceedingly challenging to do in most of the low-income countries. So where do you start drawing the line? And when you start drawing the line, do you end up making decisions with regards to prioritizing sexual health over chronic cardiovascular disease or chronic diseases? I'd be fascinated with your comments.
And before I turn to everyone, I see that there's a fourth question, so we'll grab that quickly, and then I'll turn to the panelists.
Okay, hi, I'm Anju Kane. I'm a second-year PhD student at the University of Southern California, and my question was for Dr. Karim. And at the end of your presentation, you mentioned advocating for a stronger treaty at the country level, and I was wondering if you could just talk more about what that looks like and what that looks like for students and how students can be involved in that. Thank you.
Who would like to be? Larry, did you want to start?
You want me to start? Okay. I think I'll just, there were some great questions, but I'm going to leave my fellow panelists to deal with the others. I thought I would talk, just address the question that Nina presented on Gaza. I've been doing a lot of work on that. It's also important to realize that the conflict in Gaza is horrendous, but there are conflicts around the world that are tragic as well. What I focused on as a law professor is international humanitarian law. I've written a number of articles on this. One was in JAMA, and we've been doing a series of workshops and webinars with Physicians for Human Rights. International humanitarian law is extraordinarily clear. It says basically two things, although I can go into detail if you want. I don't think we've got the time. The one is why health holds a special place protected by international humanitarian law. By health, I mean transports to health facilities like ambulances, hospitals, health workers, patients. They should never be targeted, and they have been. Indisputably have been targeted. It's a gross violation of international humanitarian law. The other is the protection of civilians. And I can go into it in detail. There's a lot of nuance behind it, but the bottom line is that there appears to be a persistent, gross violation of international humanitarian law that's taking place both in Gaza, but in other places around the world, in Ukraine and parts of Africa. So I know that the Gaza war has caused enormous conflict around the world. But one thing we should all be not in conflict about, unified, is the protection of the health sector and the health system. and yet nothing seems to change. It's one of the most sad, tragic, dispiriting episodes in my life.
Yeah, just to add on to Larry's comments on this, it was for me sort of a surprising but also encouraging moment when I learned that Human Rights Watch had actually been using the principles and guidelines on human rights and public health emergencies to conduct investigations of the emergencies that were arising in Gaza. There are, of course, public health emergencies. If you recall, the definition in the principles that we had developed was very broad, was not limited to infectious disease, we had folks on our team who actually made us look to international humanitarian law and to consider a case where there might be an occupied territory. So we engaged with this. And so what I want to say is, of course, how do you stop? The question was, how do you stop? We've seen the international legal community come out in full force, right, in denouncing the violations of international law that have been occurring. The International Court of Justice has largely sided in defense as well with with South Africa's case, and of course some might see it as a glass half empty, some might see it as a glass half full in terms of what the International Court of Justice said. But there are limitations in how far international law can go, and I think this is the moment where you see that limitation, right? This is a situation that is far beyond the reach of what international legal accountability can do. So I think and this is partly why I think Ben started with my presentation, international law is a lot more about soft law and what people do when they take tools of international law and advocate in their communities for them. And so I think that is the most powerful, that is the area where we can find the most traction with international legal principles. It's not in high-level courts, it's not in negotiating forums, it's not in, developing a new international legal instrument. It's in the ways that people vernacularize legal principles and bring them down home. So that's I think, the most powerful traction with them. But maybe others have thoughts as well.
Okay. So I will say, when I think about all the questions that were asked, one thing that strikes me is what Sophia alluded to, which is health is political. These issues are deeply political. And how these instruments come to be and how they are shaped is deeply political. I'll align myself with what my colleagues have said about what's happening in Gaza. Of course, South Africa brought, the urgent court case to receive provisional measures, which I think highlights two things. The one is that international law matters. If it didn't matter, nobody would care that the war in Gaza was declared a genocide. But it provides a starting point and an additional instrument and mechanism for advocacy. And that leads me nicely to the question that was asked about what advocacy looks like in the pandemic treaty. I think what I say is probably true for many other global health issues. But in particular, the treaty is currently characterized as something that is referential as opposed to additive. That is to say, it refers to and leans on existing global health law infrastructure and existing national laws. And so those laws can change. Whether the pandemic accord is adopted or not, there is scope within what exists currently. And we see that with the revision of the international health regulations. These instruments can evolve and begin to reflect what we morally as a society think is right. And so when I refer to advocating at a country level, that's kind of what I'm alluding to. And I think, in particular, Sophia's last slide about this being a super election year speaks directly to that. We have the power as voters within our own countries, as people who can demand change. And I think in that regard, civil society has always forced us to demand better, and so we should meet that demand. The final thing I wanted to touch on was the question about education and sort of maximization of healthcare in the context of equity. I think the question we need to ask is, outside of the healthcare system, what is shaping our health? Because the reality is a lot of health is determined structurally, and law is an instrument that helps us structure our societies. So if we want to change structural determinants of health, we should change the laws.
Well, I'm only going to align with all that my colleagues have said, actually. So just in terms of Gaza, the only thing I just want to add is that it's really important in every public forum that people keep bringing it up. And so I'm really grateful that you've brought it up here. And I think we all know the issue isn't the laws. The laws are there. The issue is the politics. And it's about how is it that we all work around what's happening politically. I also want to add on, if I may, just a little bit also in terms of that example that came up. And in terms of the, and very much, again, I think I'm going to align very much with what you were saying, which is about this question about thinking about, so you mentioned, I think, a cardiac, like a valve of some sort. So the issue becomes then, where was it developed? Where was it manufactured? Who owns the intellectual property? Who are the companies? What are the countries that are engaged with this? How is distribution being handled? What is the access that happens? Who is it that's able to demand? All of those levels raise different issues. All of those issues are flashpoints for action. And so the issue becomes, how is it that we understand, as opposed to saying this is over here, these are the only issues where this is the case. It's true for everything that we do in health. And one of the things that I think has been really important, of one of the many positive developments I think that was talked about today, in terms of what's happened with COVID, is just much more push, much more demand regionally in terms of manufacturing, in terms of distribution, in terms of what's there. And so it's about how is it that we make those systems work for all of the health issues we think matter.
So please join me in thanking our inspiring presenters, helping us to think through the ways in which we need to reform global health law to ensure global health and human rights.
And thank you, Ben.
As our panelists point out, we are at a crossroads for global health, for human rights, for global governance, and I hope that you will be engaging in this time as reforms are being written and global health is on the ballot. For those of you who are interested in human rights and global health, we have a second session tomorrow, CS 47, on climate change as a threat to global health and human rights, and I hope that you will continue to engage in these human rights reforms that are taking place, particularly at this moment when global health is hanging in the balance, and as it's so much of our world is focused on the need to reestablish our norms of justice and to structure those norms under law. So thank you so much for being a part of this conversation, and I hope to see you throughout the conference.